my video. My name is Felix Ynojosa and I'm going to talk about a medical case of a 33-year-old female that presents chronic shortness of breath. And now I will begin. Case presentation. History of present illness. A 33-year-old white female presents after admission to the General Medical Surgical Hospital ward with a chief complaint of shortness of breath on exertion. She reports that she was seen for similar symptoms previously at her primary care physician's office 6 months ago. At that time, she was diagnosed with acute bronchitis and treated with bronchodilators, empiric antibiotics, and a short-course oral steroid taper. This management did not improve her symptoms, and she was gradually worsened over 6 months. She reports a 20-pound intentional weight loss over the past year. She denies camping, spelunking, or hunting activities. She denies any sick contacts. A brief review of symptoms is negative for fever, night sweats, palpitations, chest pain, nausea, vomiting, diarrhea, constipation, abdominal pain, no sensation changes, muscular changes, and increased bruising or bleeding. She admits a cough, shortness of breath, and shortness of breath on exertion. Social history. Her tobacco use is 33 pack years. However, she quit smoking shortly prior to the onset of symptoms. 6 months ago, she denies alcohol and illicit drug use. She is in a married monogamous relationship and has 3 children, aged 15 months to 5 years. She is employed in a cookie bakery. She has 2 pet dogs. She traveled to Mexico for a 1-week vacation 1 year ago. Diagnosis. Based on the bronchoscopic findings, a diagnosis of acute pulmonary histoplasmosis in immunocompetent patient was made. The clinical presentation of the disease has a wide spectrum presentation, which makes diagnosis difficult. The mild pulmonary illness may appear as a flu-like illness. The severe form includes chronic pulmonary manifestation, which may occur in the presence of underlying lung disease. The disseminated form is characterized by the spread of the organism to extrapulmonary sites with proportional findings on imaging or laboratory studies. The gold standard for establishing the diagnosis of histoplasmosis is through culturing the organism. However, diagnosis can be established by histological analysis of samples containing the organism taken from infected organs. It can be diagnosed by antigen detection in blood or urine, PCR or enzyme-linked immunosorbent assay. The diagnosis also can be made by testing for antibodies against the fungus. Treatment. Pulmonary histoplasmosis in asymptomatic patient is self-resolving and requires no treatment. However, once symptoms develop, such as in our above patient, a decision to treat needs to be made. In mild tolerable cases, no treatment other than close monitoring is necessary. However, once symptoms progress to moderate or severe, or if they are prolonged for greater than 4 weeks, treatment with itraconazole is indicated. The anticipated duration is 6 to 12 weeks. The patient's response should be monitored with a chest X-ray. Furthermore, observation for recurrence is necessary for several years following the diagnosis. If the illness is determined to be severe or does not respond to itraconazole, amphotericin B should be initiated for a minimum of 2 weeks, but up to a year. Co-treatment with metriptyline is indicated to improve pulmonary compliance and reduce inflammation, thus improving the work of respiration. Prognosis. If not treated appropriately and in timely fashion, the disease can be fatal and complications will arise, such as recurrent pneumonia leading to respiratory failure, superior vena cava syndrome, fibrosing meningitis, pulmonary vessel obstruction leading to pulmonary hypertension and right-sided heart failure, and progressive fibrosis of lymph nodes. Acute pulmonary hypermosis usually has a good outcome on symptomatic therapy alone, with 90% of patients being asymptomatic. Disseminated hypermosis, if untreated, results in death within 2 to 24 months overall. There is a relapse rate of 50% in acute disseminated hypermosis in chronic treatment. However, this relapse rate decreases to 10 to 20%. Death is imminent without treatment. Leading causes of death. In 2018, 45 people died from chronic pulmonary disease, making it the fourth overall leading cause of death, behind heart disease, cancer, and accident, and intentional injuries. In the United States, the third disease-related cause of death. In 2008, chronic pulmonary disease surpassed stroke to become the third leading cause of death. This was due to the stroke death rate decreasing at a faster pace than the chronic pulmonary disease death rate, and a 2-year increase in the chronic pulmonary disease death rate. In 2014, accidents and intentional injuries surpassed chronic pulmonary disease as the third leading cause of death. Most leading causes of death are decreasing, but the death rate for accidents and intentional injury have been increasing since 2009, driven by the opioid epidemic and subsequent overdose deaths. In 2014, it surpassed chronic pulmonary disease to become the third leading cause of death. Gender differences. More women than men die from chronic pulmonary disease, 82,158 versus 73,887. But the chronic pulmonary disease death rate is higher among men than women, 42,900 versus 35,800 per 100,000, because the female population is larger than the male population. This case demonstrates how all interprofessional healthcare team members need to be involved in arriving at a correct diagnosis. Clinicians, specialists, nurses, pharmacists, laboratory technicians all bear responsibility for carrying out and sharing any findings with all team members. An incorrect diagnosis will almost inevitably lead to an incorrect treatment. So coordinated activity, open communication, and empowerment to voice concerns are all part of the dynamic that needs to drive such cases so patients will attain the best possible outcomes. Thanks for paying attention to my video.